Good evening, ladies and gentlemen. I'm Sandarika Herath, SR Dermatology from NHSL. My topic today for the SR update is hypomelanotic disorders beyond skin depth. Uh, as we all know, the hypomelanotic disorders are a common entity that we encounter in dermatological practice. My main focus of today's presentation is to discuss on some unnoticed extracutaneous manifestations related to hypomelanotic disorders. Uh, the skin color is actually a blend of several chromophores, out of which melanin is the major component. And the melanin seen in the epidermal melanocytes and the keratinocytes responsible for the epidermal pigmentation, whereas melanin found in the macrophages and the dermal melanocyte responsible for the dermal pigmentation. Melanocytes belong to a dendritic cell which originate from the neural crest cells, later developing into melanoblasts. They produce melanin in specialized packages called melanosomes. And out of this melanin, the melanin are of two types, eumelanin and pheomelanin, out of which the eumelanin is the pigment responsible for the brown-black color pigmentation. And once the melanin is produced inside the melanosomes, they are transferred by the melanocytes to the adjacent keratinocytes uh, through a unit called epidermal melanin unit, which consists of one melanocyte interacting with approximately 30 to 40 keratinocytes. Moving on to the process of melanin biosynthesis, it is a complex process with consists of different stages, including melanoblast migration, proliferation, and differentiation, melanin synthesis and melanosome maturation, melanosome transfer to the keratinocytes. We'll look into all of these one by one. First is the melanoblast migration. As I mentioned earlier, the melanocytes arise from the neural crest cells, which will you can see these are the neural crest cells, and they differentiate into melanoblast cells, and these melanoblast cells consist of various receptors where the ligands would be the endothelin 3, MITF, stem cell factor, and also SOX10, PAX3. For those ligands act on the receptors found in those melanoblasts, they will regulate this process of migration into the melanin containing organs. So the migration would take place as through the dorsolateral pathway or else the ventrolateral pathway. And then once the mature melanocytes are formed, the melanin synthesis occurs inside the specialized structures called melanosomes. So the melanin synthesis uh, is a tightly regulated process. The substrate is the tyrosine protein, and the rate limiting enzyme is the tyrosinase enzyme. And this tyrosinase enzyme, the structure, the function is stabilized by another important proteins called tyrosinase related protein 1 and 2. So this melanin synthesis has two components of the pathway, and when there is adequate amount of tyrosinase present, the pathway usually takes this right-sided semi-pathway to produce the eumelanin. So the defects in these enzymes will responsible for the production of to give rise to various types of ocular cutaneous albinism. And now we'll move on to the melanosome maturation stage. First, uh, Sorry for the. Um, and now the this is the rough endoplasmic reticulum where all the proteins are produced, including the fibrillar matrix proteins as well as the tyrosinase enzyme. So they are released to the cytoplasms as vesicles and also through the Golgi apparatus as lysosome related vesicles. And inside these structures, uh, melanin is generated once tyrosinase is acquired into these melanosomes. And once melanin is produced, it is incorporated with the fibrillar matrix and melanin is generated, and there will be four-stage maturation of these melanosomes before being transferred to the keratinocytes. And once this melanin is generated inside the melanosomes, these melanosomes are transferred to the periphery of the melanocyte towards the dendrites, and that is which will be helped by the microtubules shown in this figure. And once they reach the dendrite, they will be transferred to the adjacent keratinocytes, which I have enlarged in this picture. These are for this transfer, specialized proteins will facilitate this transfer. This is the melanosome, and this melanosome is attached to the actin, which will which will direct the melanosome to the keratinocyte, and this attachment is facilitated by Rab27A melanophilin and myosin 5A proteins. These are important in certain hereditary hypomelanotic disorders. And moving on to my proper topic about extracutaneous manifestations. Extracutaneous melanocytes are found in organs which contain pigment as well as, now we already know that there will be pigmentation in the skin and the hair follicles. In addition to those already pigmented areas, the unnoticed structures like the eye, including the retinal pigment epithelium and the veal tract, the cochlea of the inner ear, CNS, including the leptomeninges and the brain matter, heart, adipose tissue, and lungs also found to have extracutaneous melanocytes. These are the already mentioned structures. And moving, we'll discuss about those extracutaneous melanocytes. First, the ocular melanocytes, as I mentioned earlier, there are two populations located in these areas, and they function in absorption of light that comes through the retina, and it will stop bouncing effect of the photons and overstimulation of the rods and cones. And also they have phagocytic processes of the photoreceptor membrane to allow clear vision, and also they have some function in the retinoid metabolism as well. And next is the ocular melanocytes, otic melanocytes, which are also known as intermediate cells, located in the stria vascularis of the cochlea. That is, there is an endolymph containing chamber inside the inner ear, which will house the major sound detecting organ, which is known as organ of Corti, and the one of the wall of this chamber is formed by the stria vascularis. So it is important for the normal hearing and the endolymph maintenance, and it protects the cochlea from ototoxic drugs and function in some calcium homeostasis to improve hearing, and also the melanocytic granules play a role in maintaining body balance as well. Next is the cephalic melanocytes. Cephalic melanocytes produce two types of melanin, neuromelanin and the melanosomic melanin. This melanosomic melanin is similar to what is found in the skin and it is found mainly in the leptomeninges. But the neuromelanin found in the brain matter like substantia nigra is chemically different from the normal normal melanin. The functions, they have some neuroendocrinological functions including sleep regulation and also play a role in protecting neural tissues from toxic substances. Then we'll move on to the various types of hypomelanotic disorders with extracutaneous manifestations. I have listed them according to the site of the defect. First, the defects in the embryological development and migration of the melanocytes. As I mentioned earlier, the defects can be related to the PAX3 SOX10 endothelin receptors. One of the well-known disease is Waardenburg, and defects in melanogenesis, which starting from tyrosine to the production of melanin give rise to ocular cutaneous albinism. Defects in biogenesis of the melanosome. The organelle formation, the melanosome organelle formation is defective in Hermansky-Pudlak syndrome and Chiriak-Higashi syndrome. And defects in melanosome transfer related to the already mentioned three proteins that attaches the melanosome to the actin filament is defective in Griscelli syndromes, three types. And also the next condition is an acquired condition that is due to defects in survival of the melanocytes, vitiligo, and also other hypomelanotic other disorders. One consists of tuberous sclerosis and hypomelanosis of Ito, which give rise to localized hypopigmentation. We'll first talk about one of the common hypomelanotic disorder with extracutaneous manifestations, vitiligo. So it is a systemic disease with selective loss of melanocytes in organs containing melanin, including the skin, ovial tract, retinal pigment epithelium, inner ear, and the leptomeninges. So this damage can be due to autoimmune, neurohumoral, and autocytotoxic mediated mechanisms. There are certain few studies have done regarding this aspect worldwide, and it was shown that the systemic involvement of the melanocytes is commonly seen in the non-segmental forms of vitiligo. And we'll talk about the clinical manifestations related to loss of melanocytes in different sites. First, the most commonly found skin manifestations, depigmented macules or patches, along with leukotrichia. And the areas commonly involved are the normally hyperpigmented areas. And next, the ocular manifestations, usually seen around approximately 60% of vitiligo patients. The commoner ones include hypopigmented spots on iris, retinal pigment epithelium, hypopigmentation. But some serious manifestations like uveitis also found in approximately 4 to 9% of patients with vitiligo, and chorioretinal degeneration, and also they will commonly have dry eye syndrome. So the important observation made is most of these features are associated with the periorbital type of vitiligo, and also most of them do not have any loss of visual acuity. So we need to have a high index of suspicion, and also it is recommended to at least to look into these features at least in the selected cases like periorbital vitiligo to exclude ocular involvement. And next is the ear involvement in vitiligo. Commonly observed association is sensory neuronal hearing loss, which is said to be prevalent in 4 to 20% of patients from the studies done worldwide. And again, it is shown, it is commonly associated with the non-segmental forms, and it was also observed that is no correlation with the duration. So with this observation, it was hypothesized that the ear involvement may be happening in the beginning, active stage of the disease, and then later on it will not progress beyond after the stabilization. Again, this hearing loss will be asymptomatic to the patient, only apparent with the audiometric and other relevant investigations. And also, now these studies have done worldwide and found to have some racial differences with the manifestation of this ear involvement. And even the studies done in our region, including India, has shown significant association, but some fail to show any correlation between the two. At the moment, none of the studies have done in Sri Lanka to find any significant associations. Therefore, we cannot recommend. We cannot comment on the feasibility or the how to select the patients to screen for the development of auditory manifestations. Therefore, I thought it would be an interesting area to study more on. So I have selected this area as my MD research as well. Uh, so, but at least we can recommend the patients with vitiligo should be cautious with the use of ototoxic drugs and also exposure to loud noise. And in addition to the melanocyte-related manifestations, vitiligo can have other autoimmune associations, including common ones include autoimmune thyroid disease and also certain autoimmune polyendocrinopathies. These are the other autoimmune manifestations related to vitiligo. And moving on to a rare disorder of which is related to vitiligo, Vogt-Koyanagi-Harada syndrome. It's a rare multisystem disorder that affects tissues containing melanin, including eye, ear, meninges, and the skin. Again, it is mediated via an autoimmune process. And therefore, they can have other autoimmune manifestations as well. So the patients present with the disease progresses in 4 stages: a prodromal phase of flu-like illness, an acute uveitic phase followed by involvement of neurological and hearing defects, and the convalescent stage with appearance of the skin manifestation with the resolution of eye manifestations, and also some may have chronic recurrent uveitis later on. So the ocular manifestations in the form of tan uveitis leading to retinal degeneration, and auditory in the form of sensory neuronal hearing loss and vestibular symptoms like tinnitus and vertigo, meningism, skin manifestations with vitiligo, poliosis and alopecia. Alessandrini syndrome is also another rare disorder associated with vitiligo due to autoimmune destruction in a genetically predisposed patients, presence with unilateral vitiligo classically, and poliosis and unilateral retinal degeneration. But unlike with Vogt-Koyanagi-Harada syndrome, the involvement of the 8th cranial nerve and other neurological manifestations are not seen. We'll discuss on other neurocrestopathy of Waardenburg syndrome due to defective melanoblast maturation and migration. So these are the already mentioned mutations which will mediate this melanoblast migration. Classic features include cutaneous manifestations of white folla, which is the most commonly seen, and in the absence of white folla, premature graying of hair, associated with white eyebrows and eyelashes, and patchy depigmented areas of the skin of the limbs, abdomen, and the thorax. Extracutaneous manifestations, hypoplastic eyelids, heterochromia. These hypoplastic eyelids give rise to brightly blue colored eyes, and heterochromia can be partial or complete, and sensory neuronal hearing loss. And this is one of the patient that we have encountered in clinical meeting with Waardenburg syndrome. The patient is having all the features as well as evidence of hearing impairment. Further four types identified on the basis of presence or absence of additional features. So the classic Waardenburg would have dystrophia canthorum, synophrys, and broad nasal root. And type 2, similar to the first one, except dystropia canthorum. And type 3, dystropia canthorum, in addition, musculoskeletal abnormalities. Type 4 have other neurological involvement, including aganglionosis, giving rise to Hirschsprung's disease and other neurological manifestations. Next disease is ocular cutaneous albinism, which is a disease with generalized reduction of pigmentation since birth due to defects in the melanin synthesis. And that only the melanin synthesis is defective, the number and the structure of the melanocytes are normal. In addition, they can have visual impairment and hearing defects. Again, there are few types depending on the which protein is affected. If there is total loss of tyrosinase enzyme, the patient will not have any pigmentation at all, and for the lifetime. No pigmented nevi, the skin appears pinkish colored, and they will have eye involvement with blue-gray iris, prominent red reflex, and poor visual acuity and other eye manifestations. And this is one of the patient with ocular cutaneous albinism. Type 1b, there is significantly diminished activity of tyrosinase enzyme. Therefore, they have some pigmentation from the beginning as well as they acquire pigmentation later on. Type B is mutation of the P protein, which is necessary for the trafficking of the tyrosinase enzyme. They have some pigmented hair at birth, and also birthmarks also visible. Eye signs are less severe. Type 3 is due to mutation of the tyrosinase related protein 1. So they will have red color skin and hair, minimal visual disturbances. Another disorder associated with the ocular cutaneous albinism is Hermansky-Pudlak disorder, which is due to defects in function of the intracellular organelles in secretory cells, including melanocytes as well as platelets. So there is less development of platelet granules, but there is the tyrosinase enzyme is still preserved. So the skin manifestations similar to ocular cutaneous albinism. In addition, they can have bleeding manifestations and other lung fibrosis and granulomatous colitis. Celiac Higashi, again a disorder of lysosome organelle related structures due to mutation of the LIST gene. The vesicular trafficking is defective. The patient present with albinism, silvery gray hair. And the extracutaneous manifestations include eye pigmentation is affected, with reduced visual acuity, and because this neutrophilic phagocytic system is also defected, they are more prone to get bacterial infections, bleeding due to platelet granular defects, and also some neurological impairment as well. Next syndrome is Griscelli, that is due to defective melanosome transfer to the keratinocytes. So they present, most of them present with silvery hair, pigmentary dilution, but unlike in previously mentioned disorders, the eyes are not involved. And they again can have either immunological defects and neurological defects depending on the type of Griscelli. So this is a patient with Griscelli syndrome with silvery hair, and this is a picture of a hair microscopy showing large clumps of melanin. So there are three types as I mentioned before. The type 1 is due to myosin 5A mutation. So they will have the classic skin features, but normal immunity can have bleeding manifestation. The type 2 RAB27A mutation, so they are prone to bacterial infections. Type 3 is due to melanophilin mutation. They have only the skin and hair manifestations. A disorder of localized pigmentation is hypomelanosis of Ito. So it's a type of pigmentary mosaicism with extracutaneous manifestations. So this is explained as there is presence of two cellular clones of melanocytes, normal clone and a clone with genetic abnormalities acquired in the early stage of embryological development before the migration. So the cutaneous features include maculo-hyperpigmented whorls, streaks and patches in Blaschko-linear distribution, and extracutaneous manifestations involving various organs, neurological, ophthalmological, dental, skeletal, cardiac and renal abnormalities. And tuberous sclerosis complex, although it is known as a neurocutaneous disorder of prominent hematomas, but in addition to this prominent feature, they can have reduced this hypopigmented, hypomelanotic skin manifestations due to reduction of the melanosomes in the melanocytes and the keratinocytes in these areas. But the exact mechanism of this melanocyte loss is not very well explained. So they can be present in the form of ash leaf macules or confetti macules. Again, they can present with white hair, hypopigmented iris spots. So in summary, hypomelanotic disorders are due to either congenital or acquired defects in the development, function and survival of melanocytes. Melanocytes are found in the skin and extracutaneous organs and play various roles in maintaining physiology. Although the pigment loss is the striking manifestation, hypomelanotic disorders can be accompanied by extracutaneous features, including most commonly visual, auditory, and neurological defects. Therefore, it is recommended to consider these possible associations in managing patients with hypomelanotic disorders. So that brings to the end of my presentation, and these are the references. And I would like to thank Dr. Janaka Akkaravita, my consultant in my supervisor consultant at NHSL, for guiding me to in preparing this presentation, and also Dr. Indira Kahavita for giving me the opportunity to present in this forum. Thank you very much.